Hello, I'm James Wagner, and I'm from the University of Michigan. I'm a co-investigator on the National Dementia Workforce Study, and I'm mainly responsible for sampling and oversight of the data collection, and that's what I'm going to be speaking with you about today. So there's a family of four surveys that we're going to be looking at today. The first is a community clinician, and that's a sample of physicians, nurse practitioners, and physician assistants. So it's a sample of individuals. And we're grouping the other three surveys together because they have very similar designs that are also different from the community clinician survey. That is, they're two-stage surveys. In the first stage, we sample organizations like a nursing home, assisted living community, or a home care agency. And in the second stage, we sample staff from those organizations. And the survey content is nearly identical across those surveys, both the staff and administrator surveys. And we'll take a look at the sampling and design in more detail for those surveys in a moment. But let's start with the community clinician survey. So we want to interview clinicians who've cared for a patient with a dementia diagnosis. So how do we identify those clinicians? Well, in the first step, we identify all people living with dementia using a validated algorithm applied to Medicare claims plus MA encounter data, and we also use MDS assessments. And so the procedure allows us to identify the full population of persons living with dementia who have a diagnosis in the system. In step two, we identify the clinicians that care for and or prescribe to people living with dementia. And we split them into 6 license or specialty groups, including physicians. So that includes internal and family medicine, um, geriatrics, hospice and palliative medical care, neurology and psychiatry. And nurse practitioners, we have pulled from primary care and psychiatry. And then we have non-surgical physician assistants. So over the 5 years, we're going to interview 12,000 unique respondents, and we're going to complete 20,300 completed surveys over 5 waves. So that means we're going to interview some of these individuals multiple times in order to see how their experiences change over time. In the first year, the sample we drew was drawn from a frame that included about 490,000 clinicians, just to give you some sense of the size of the population that we're looking at here. So that's after we went through step one and step two, we had about 490,000 clinicians from which to draw our sample. We're oversampling some license and specialty groups just to be sure that there's sufficient power for analysis of these subgroups. In year one, we're going to complete the surveys in the numbers that you see. This is the plan in the table on this slide. We're going to complete 10,000 interviews in the first year. And we're oversampling some groups, specifically groups 3, 4, 5, and 6, relative to other parts of the population, just to be sure that we have sufficient sample size for different analyses. Now let's talk about the nursing home and assisted living community staff surveys. So the organizations are the starting point to build the sample. That's that first stage of sampling. But it also facilitates linkage to care and outcomes data. So nursing homes are certified by CMS, and assisted living communities are identified by state license lists. So that gives us ways to build the frame from data at the federal level or at the state level. Year one for the assisted living communities is based on a sample of states. We built a sample of 20 states from the 50 plus DC states in the first year and assembled lists for all assisted living communities in those 20 states. In year two, we're going to expand to include all states, right? So we'll have complete coverage of assisted living, at least assisted living registered with state level agencies. In step one, we developed a stratified frame of organizations which are recruited to participate. So nursing homes are assumed to have people with dementia, and assisted living will be asked if they could ever have residents with dementia. So they won't necessarily have to have residents with dementia at the moment they're sampled, but if they could, they would be eligible. So assisted living would have to be highly specialized to not include people living with dementia. That is an exclusion criterion. The organizational administrator will be asked to complete a survey about the organization. In step two, we'll obtain a roster of staff, specifically RNs, LPN, direct care workers. I'll show you a list of all the included titles near the end of the presentation. But we're not including physical or occupational therapy, facilities and food service staff, and some other categories of employees that many nursing homes and assisted living communities would have. Once we have those rosters of the eligible titles, we're going to sample from them. And our goal in the nursing home survey is to interview 7,700 unique respondents. We're going to interview some of those staff will interview multiple times, and that will result in 19,140 completed surveys. And we're going to recruit 700 nursing homes from which these staff will be sampled. So that gives you some sense, and I'll show you more detail in a later slide to see how that's actually going to happen over the 5 years. In the assisted living communities, we're going to interview 6,300 unique respondents. We're going to complete 15,660 surveys with those 6,300 unique respondents. Again, longitudinal follow-up with some of those respondents. And we're going to do that by recruiting 700 assisted living communities. And again, I'll show you those numbers in a detailed table in a few slides. So home health and home care provide some challenges. Home delivered care comes from multiple types of agencies, not all of which are licensed by states, plus there's direct hiring. So Medicare reimburses only home health agencies, which provide shorter term care, as opposed to the kind of longer term care we might also be interested in. Medicaid can reimburse personal care, which focuses on support for activities of daily living, or ADLs, but state policies differ. Some states' Medicaid plans have consumer directed models of care through which households hired directly. So, in year one, we are going to recruit agencies that are registered with CMS. They are certified for home health services. And we estimate that 20 to 40% of these agencies also provide personal care services. It's a little hard to know, but we've been looking at several states to try and compare what we see across multiple databases and see if we can see what's the percentage of the CMS registered agencies that supply personal care services. And in the administrator survey, we'll then ask them to specify the type of services that are provided. In step two, similar to the other organizational surveys, we'll obtain rosters of staff from agencies, and we'll get lists of RNs, LPNs, and direct care workers. We'll sample from the rosters, and we hope to have 8,400 unique respondents, and we're going to interview those 8,400 unique respondents 20,560 times over the next 5 waves, so that we'll have, again, that follow-up to see how their experiences change over time, their career changes over time. And that'll be very valuable in understanding change in the workforce. We know that the CMS registered agencies are not a complete list of the target population, and so we're working in year two to expand the sample frame. We're going to start using state licensing lists to identify home health and home care agencies in year two. And we're focusing on two, not exclusively, but two kinds of regulatory requirements across the states that'll help us advance this goal. So one is the personal care aid training requirements that many states have. So following that those regulatory agencies across the states gives us a way to secure a list of home care agencies in states where they have PCA training requirements. Not all states do. Other states have managed long-term services and supports programs that we can also use to help identify lists of home care agencies that are not registered with CMS. Now, across these two types of regulatory requirements, about 40 states have one, the other, or both of these types of regulations. So not all states have these regulations, and it means in some states it's going to be difficult to assemble lists of home care agencies. So that's why that last bullet says there still likely will be undercoverage of the population. And of course, direct care workers who are hired outside of an agency wouldn't be covered by any of these approaches. So it's another area where we might want to consider how can we further improve our coverage. All right, so stepping back now and looking at all of the surveys, here we're looking at the stratification that we've used to draw the sample in the first year, right? So we're looking across all 4 surveys. You'll see the community clinician on the survey on the far right, then the far left, then the nursing home survey, the assisted living survey, in the third column, and the home care in the fourth column. The first row gives measures stratification that are based on things that might be thought of as the size of the organization, the facility, or in the case of the clinician, the number of patients that they have. Okay, number of patients with dementia. So for nursing homes and assisted living, we have the number of certified beds as a kind of a measure of how large is that organization. For the home care agencies from CMS, we have the number of Medicare episodes of care that were provided. Again, is a rough measure of how large is that agency. One of the dimensions of underservice for people living with dementia is in rural areas. And so we've created separate strata for urban and rural in each of the surveys. And then the third row are also indicators of being underserved. So in the community clinician survey, we use the total number of dually eligible or LIS dementia patients associated with that clinician. For the nursing homes, we have the proportion of residents who are paying via Medicaid. And for home care agencies, we have the proportion of the population in the local area using Medicaid alone for insurance. So we have those variables available for stratification. In the assisted living and home care agency surveys, we also use census region to give us some geographic control of the sample. Finally, two other dimensions of stratification in the community clinician survey are the setting, which includes are they residential at all, outpatient, in other words, non-residential, and Part D, prescriber only. And then the last row is the clinician license or specialty, which I mentioned earlier. Are they a primary care physician, psychiatrist, neurology, primary care nurse practitioner, psychiatry nurse practitioner, or non-surgical physician's assistant? So those are the strata that we're using in the community clinician survey for clinician license and specialty. And this is that table I mentioned a few minutes ago that shows the 4 different families of surveys, the year, and the new surveys that we plan for each year. That's the first row for each survey, the new surveys. And then the follow-up re-interview that we plan to do in subsequent years. So in year 2 of the community clinician survey, we're planning 2,000 follow-up interviews. And you can see on the left-hand side the totals of all the surveys, how many surveys we plan to complete over the years and how many unique respondents we plan to complete. So we're planning to complete 75,660 surveys across 34,400 different unique persons. We also plan 700 nursing homes to be recruited, 700 assisted living communities, and 1,050 home care organizations, agencies. So that gives you some sense of the sample size and when it'll be recruited. Of course, this could be subject to change as plans develop, as we learn more about difficulties with recruiting different parts of the population. We might want to change what we're doing here. But this is the plan that we have started with and that we're implementing certainly for year 1 and working towards for year 2. Now I'm going to describe a little bit about the data collection in each of the surveys. I'm going to start with the community clinician survey. In the community clinician survey, the first step that we're taking is to update contact information. And we're doing 2 types of locating activities. The first is passive location. And we're using updates from commercial databases as the NPES is often outdated, right? So people enter their information into the NPES early in their careers often and maybe don't update it as frequently as they should. And so the information can be outdated. So we use information from commercial databases to try and update the contact information that's available. And then we're going to do some active locating activities. So RTI, our partner in the data collection for the community clinician survey, is going to do outreach to update contact information. And they're going to use mail, email, and telephone to try and contact persons who are sampled for the community clinician survey. Once we have that updated contact information, we're going to reach out to request survey participation. And our messaging is pushed out through 4 different modes. One is mail, another is email, and also using SMS or text messaging. And then we're also going to place telephone calls. So that gives us multiple different modes of contact, which is a strong approach to recruitment to surveys, very effective approach. We're also doing in the first year an incentive experiment offering three experimental treatments. The first is a $100 contingent or postpaid incentive. So once you've completed the survey, we send you the token of appreciation or incentive. The second arm is called an early bird treatment, where we're offering a slightly higher incentive to people who are willing to respond within the first 10 days. So it's a $125 incentive for the first 10 days and $100 after that to encourage early participation. The third is using a contingent incentive upfront, a non-contingent incentive upfront. That is a prepaid $10 incentive, right? So the incentive is paid regardless of participation. It's a part of the initial contact messaging. And then once the survey is completed, an additional $90 is postpaid after the survey is completed. So those are the three arms, and we're going to learn something about what's most effective across the strata of our population. And we may have to then alter our incentive plan for year two based on the experimental results, or implement the incentive plan based on the results from year one. We're offering two modes of completion, web and paper. And we're going to do some non-response follow-up in the community clinician survey, and that's where we're going to use the telephone. And we hope to target cases to minimize the risk of non-response bias. For the other three surveys, we have a very common design across the three surveys. So the nursing home, assisted living, and home care surveys start with a first stage sample of establishments. And our goal for year one is 100 organizations in each survey. The administrators are going to be recruited to complete a questionnaire about the facility, the community, or the agency. And we also ask each establishment to provide a roster of eligible staff. And we provide we provide an incentive to the establishment. So we're experimenting with the incentive structure. In one arm, we're going to give $1,800 to the establishment and $200 to the administrator who carries out these tasks. So that's one incentive treatment. And the other incentive treatment is just to give the $2,000 to the establishment. And we'll see how each of these treatment works. Again, we can then alter our incentive design for year two based on the results of this experiment. We're using three modes of contact to reach out to the agencies, facilities, and communities in year one: mail, telephone, and email. And we're going to use telephone specifically for that non-response follow-up as with the community clinician survey. It's a powerful tool, but we need to deploy it carefully to reduce the risk of non-response bias. And we also note that in the messaging for each of these surveys, the recruitment materials for each of these surveys, that the Alzheimer's Association has provided a statement in support. All right, so I mentioned earlier that there are a set of eligible titles for each of the surveys. We talked about who's eligible for the community clinician survey. So these are the titles for each of those agency, community, or facility surveys, right? For the three surveys: nursing home, assisted living communities, and home care. I'm not going to read all of these titles, but here they are for you. I think they fit with basically what I was describing earlier. As you would expect, activity staff in both assisted living and home care agencies are included. So these are the eligible staff for rostering. Now in stage two, once we have a roster of the persons in those eligible titles, we're going to select a sample of staff. And then we're going to reach out to contact the staff to request survey participation. We're going to be reaching out in four modes again: mail, email, SMS or text messaging, and telephone, given the available contact information that's what's available to us. We have a $100 incentive, and in two of the studies, the nursing home and assisted living community survey, we're going to be conducting an experiment. And again, that experiment, similar to one I described earlier, a $100 postpaid incentive contingent on completion of the survey. And the other arm, we're going to give a $10 non-contingent prepaid incentive. And then once the survey is completed, the $90 incentive. So we'll experiment with those options and see which is more effective. The same modes of completion, web and paper, and again, non-response follow-up using the telephone, which is a powerful tool with a human intervention from our side to try and recruit persons to participate in the survey. So that's the sampling and data collection plan for year one and beyond.